Hello, everyone. I want to thank you so much for inviting me to speak at the Israeli Physiotherapy Association conference. I have fond memories of my travels there, and I wish I could have been there. Before I get started, I do want to wish you well, and I cannot even fathom all the things you're dealing with right now, and my thoughts and prayers are with you. Now, Narit asked me to do this little presentation, this introduction, a little bit platform, if you will, keynote, and I decided to focus on pain neuroscience education and pain neuroscience education plus, which we'll discuss, and the idea of fear and disability. What I decided to do in this little presentation is really merge the world of behavioral medicine and pain neuroscience education. Many people obviously think, for a lack of a better term, of me as well. Adrian teaches people about pain, so P&E, right? Pain neuroscience education. But I want to show you how these two worlds actually beautifully merge together. In 2000, Professor Johan Vlein and Steve Linton gave us this incredible iconic model called the fear avoidance model. I hope most of you that are watching this and going through this will know this model and go, yeah, I've seen it. By the way, if you haven't, you should definitely check it out. In 2000, the idea was simple. You have an injury and then you have a pain experience. You can then pick which direction you want to go. The one that we've been focusing on is this idea that you get yourself hurt and then you start catastrophizing. And catastrophization is obviously when you see the cup as half empty or you only see the bad side. It's often driven by the words we use in therapy, the x-rays, the MRIs, the imaging, the internet, all of those horrible experiences. And then you start developing fear. Fear drives avoidance, avoidance leads to disuse, depression, and disability, and then that starts fueling this cycle of pain. By the way, we don't spend a lot of time on the other side because people don't come and see us. They hurt themselves, they go, yeah, I'm good, very low levels of fear, and they move on. In 2016, this model was a little bit updated by the same authors, and they've changed a few key things. If you look at the model, you'll notice nociception is at the top and not injury. Why? Because injury and pain is two different things, right? You can have an injury and no pain. Nociception, just a fancy terminology for information coming into the nervous system, and then we may develop a pain experience. The critical element in 2016 that changed, however, is this idea of high threat, low threat, but also focusing on pain versus function. People that move into the cycle of pain are heavily focused on their pain. They're heavily pain focused, and that's what we think is a major concern for us in the medical model. The other one is where people really focus on function. They focus on what they need to get done and they drive them towards their goals. I need to get my things done. As I'm doing this recording, I live in a very rural part of America. It's harvest season. There are farmers out all over right now harvesting. And when they get an injury, they don't have time for pain, if you will. It sounds kind of silly, but they have to get going. There's things we have to get done. Fair enough. Now, why this model? Because recently I was asked to speak at an orofacial conference, and I started searching a little bit information in that area. Orofacial pain is not a big deal in the United States yet in physiotherapy, but I found this very iconic little model, and I love this because it added a component that is not often described. Remember, Johan Vlein, Steve Linton, Crombez, who's the three behavioral psychologists in that space, are behavioral psychologists, and they talk a lot about behavior. But what this little model was given to us in 2021 is it adds another component, which I think the physiotherapists will find extremely interesting. It added hypervigilance of the nervous system. Because somewhere in this behavioral model, there is an upregulation of the nervous system. If pain science is new to you, you've been on a different planet, you've been on Mars, and you suddenly land on planet Earth and say, what's up with pain in this on this planet? We now know unequivocally that when a human being experiences pain, there is an upregulation of the nervous system. You could literally sprain your ankle today, a simple basic ankle sprain, but the nervous system will ramp up around your ankle, your central nervous system will respond, the brain will respond, and this upregulation is a critical element of a human pain experience. In persistent or chronic pain, it just keeps going, so it stays hypervigilant. And there are so many amazing things that happen. So why this model, and why when Rick asked me to do this presentation, did I decide to do this talk? Is because I think we often think of behavioral medicine on one side and pain science on the other side, or let's call it today psychologists here, physiotherapists here, but these models beautifully work together because we now know that things like fear and catastrophization can actually ramp up the nervous system as well. So let's get started. And I think this is kind of really cool. If we talk about the first part of this model, we talk about the idea of nociception, and then you get a pain experience. I think it's imperative for us to understand today that the intensity and duration of acute pain powerfully predicts pain experience, but also the development of chronic pain. It is actually funny, but there is a number. The number that keeps showing up is equal or more than 5 out of 10 on a 10-point visual analog scale or a numeric pain rating scale. In studies in whiplash injuries, Colles fractures, CRPS, the numbers are consistent. For some reason, this number 5 or above actually is strongly correlated to more pain. We also know that when we hammer in and barrage into the central nervous system, there are significant changes in the central nervous system in the brain, hence the term nociplastic pain, if you will. Now, in this little image that I have here, there's something I do want us to quickly talk about. We have been taught traditionally, and I've been a physiotherapist for more than 30 years, so I'm the traditional view. The way I was taught in physiotherapy 30 plus years ago now is, if I hurt myself today, my pain lasts a certain amount of time, it's acute pain. If it lasts a bit longer, it's subacute, then chronic. We now look at it more that there is a subgroup of people early on that develop all the characteristics that sets them up for chronic pain. And one of it is strongly predicted by these nociplastic changes driven by an upregulated nervous system. If you go to the second part of this little model that was revised in 2021, pain experience, how we experience pain early on, strongly, powerfully predicts pain later on. We know kids in neonatal ICU units with needle sticks, sports experiences in sports, circumcisions being tied to it, dentist visits, all these different things sets you up for future pain experiences, good or bad, by the way. If you had a good experience, you'll have a good experience later on. We know in surgery, as an example, that previous surgical experiences powerfully predict future experiences as well. We also know the importance of parental influence, if you will. Think about catastrophization, etc., driven by a parent, if you will. And then the brain can also memorize these experiences powerfully. That's why the hippocampus shows up so powerfully in the brain scan studies. If you continue the model from nociception, pain experience, we move on next to catastrophization. Now, catastrophization, as I mentioned earlier, is the inability to foresee anything but just the worst. This is bad, right? It's driven, by the way, by negative words that harm, torn, ripped, rupture, bulge, herniate, these bad words, and even images, right? We see the images on the internet. We now know Dr. Benedetti, who, in my opinion, and many of my colleagues, is probably the world leading authority when it comes to studying placebo, has shown us when we start catastrophizing, the brain actually decreases its endogenous analgesia. It dries up, if you will, the enkephalins, the endorphins, serotonins, etc. We also know that this is powerfully driven by things like trust, including the fact that there's a larger and larger, at least where I have been studying and looking at, an increased distrust of the medical system, especially for people in chronic pain. They have not been treated that well. Loss framework is when you only see the bad, right? You don't see the positive. And we know that this is a significant shift. Over time, this circuitry in the brain also then shifts to the emotional parts of the brain, and all of these have been tied to the brain decreasing its endogenous analgesia. The next phase is pain-related fear, right? The famous quote at the bottom of that slide there by Gordon Waddell, the late Gordon Waddell, I should say, the fear of pain is worse than pain itself. We now know in physiotherapy powerfully that fear predicts pain, and fear drives a lot of the pain experiences we see in the clinic, especially fear of physical activity. And it strongly drives it. That's why we need to study it, because when the brain starts perceiving a significant threat, it'll actually start turning on these systems quite a bit. Strongly driven by experiences, beliefs, knowledge, all those things. P&E, by the way, changes people's thoughts, feelings, beliefs, knowledge, experiences by changing some of these narratives that are given to them in rehabilitation. The next phase, which I find, again, if you're a traditionalist, you'd know we'd go from fear to fear avoidance and then start the cycle. But there's this side part, which I find extremely fascinating, and I'm so excited it was brought into this little model, is hypervigilance of the nervous system. We now know that the nervous system starts waking up very, very powerful. We know from all the work by Anina Schmidt that if you now irritate the nervous system, a nervous system gets compressed, irritated, there is a neuroinflammatory process which starts an immune response. And an immune response has been tied to demyelinization, axonal loss, upregulation of ion channel expression, which increases sensitization of the nervous system. As many of you would be very aware of the work by Professor Marshall Devor. And so the nervous system is not a passive bystander. It's not just a conduit that sends information. It actually can wake up, if you will. I know I'm making a big deal out of it, but this is fundamentally important because the pharmaceutical side is trying to develop drugs to calm that nervous system down. Then we get to avoidance, and we do know that the minute you start getting this pain-related fear, you start avoiding things. And I think in our space, in the therapy space, one of the areas which is not getting a lot of attention, and it should, is this idea of neglect. We now know that when we start getting to a pain experience and the brain goes in full alert, we can develop a full neglect. The same thing we see in neuro, in a stroke as an example. And that is probably where we're getting into conditions like CRPS, which we can now powerfully show neglect, etc. So this brings us full circle, right? We go from nociception, pain experience, catastrophization, pain-related fear, avoidance, disuse, depression, disability. It fuels a cycle, the original cycle. But I do want you to understand that, wait a minute, the minute you get there's also hypervigilance of the nervous system, which can drive this very, very powerfully. So clinically, the question would be, so what, Adrian? Why did you choose this little topic that they gave you time to speak about? Is because this actually tells us what we need to do in clinical practice. If you go to pain, let's go to pain as an example. We need to measure it, right? When patients come in, what's a pain? Well, you can measure it with a numeric pain rating scale, visual analog scale, whatever your measurement would be. Pain catastrophization, we measure it with the pain catastrophization scale. Pain-related fear, we have fear avoidance belief questionnaires, Tampa scale of kinesiophobia. Hypervigilance of the nervous system, we start looking at things like what? Pressure pain thresholds. We start seeing things like the LANCE, the pain detect, the central sensitization inventory, things like neurodynamic testing for mechanosensitivity. So we are well equipped to assess these patients. Avoidance, and I specifically focus on altered plasticity for us here, but avoidance, by the way, can be tested by fear avoidance. We talked about that, but things like two-point discrimination and laterality, facial recognition programs, all of those can measure, for example, a neglect. We now know some of that work from the graded motor imagery, and this use, depression, disability. We can think about things like, well, disability can be Neck Disability Index, the Oswestry, the Roland Morris. We can think about depression, well, the PHQ-2, the PHQ-9. There's a whole bunch of those questionnaires out there. The point is that when we pick these tools, it's because we're trying to figure out where in the system our patient lives. Now, the neat part about this is if you take all of this stuff and a patient walks in our clinic on a Monday morning and say, hey, Adrian, I'm here, I have got chronic pain, I've had it for 20 years, they're probably going to have everything on the right-hand side. They're going to have self-reported pain, disability, depression, some form of depression, pain catastrophization, fear avoidance, kinesiophobia, the list goes on. But this is why they show up the way they are, because they're in this area, and there's pieces of this that's coming together. And again, why do I like this? Because it brings in the hypervigilant part of the nervous system. Otherwise, it's just behavioral psychology. And most physiotherapists do not do behavioral psychology. We're physiotherapists. We do exercise, movement, all the cool stuff that makes us who we are, pretty much. So if I now jump a little forward, it brings me to this idea of P&E plus. Now, P&E, pain neuroscience education, is really powerful. We have good research that has now shown it works. I'll discuss that in a minute. But if you read it today, again, want to think, Adrian, what can I do to change a person's life in chronic pain? We strongly recommend, and the research strongly supports, that you got to do one of three things at least. Not one of three, you got to do three things at least. One is you got to change how they think. We got to move them, and you got to calm the nervous system down. And that could be medically or non-medically, right? Non-pharmacologically, which is what I do as a physiotherapist. So if you're going to change how they think, you've got to change their cognitions. And that could be cognitive behavioral therapy, trauma-informed care, motivational interviewing, positive psychology. We just happen to be spending a lot of time in the last 20, 25 years in physiotherapy on something called pain neuroscience education. So that's one way to do it. And so maybe you were trained in things like positive psychology, cognitive behavioral therapy. Awesome. we can talk about who needs what. That's another conversation. Then we're going to move them, and it can be traditional or non-traditional. And then calming the nervous system down. And the cool thing today is there are so many ways in therapy we can actually dampen the central nervous system down. And so we have to do these three parts together to really help our patients. I would dare to say that when I entered physiotherapy 30 years ago, we were heavily in the movement part, right? We gotta move you. Yeah, but I hurt. Yeah, but we got to move you. Then P&E showed up, and what I'm very excited about is the therapeutic ways of calming the nervous system is getting a lot of good attention. Things like mindfulness-based stress reduction, breathing, sleep hygiene, nutrition. These things are now showing up in mainstream journals. Jumping forward, let's talk about cognitive therapy, the bucket number one, if you will. We now know that there is more than 24 systematic reviews and meta-analyses that shows P&E works. You can look at it again and again. I know I'm biased. I just wrote an editorial, and by the way, I had to very significantly address some of the concerns. And it doesn't matter really how you look at it. It actually really works well. When you teach people about pain, the pain rating goes down, which is really cool. That's what we want. Then knowledge goes up, change their cognitions, visibility changes, fear catastrophization goes down, fear avoidance goes down, we change their attitudes, beliefs, and behaviors, they move more, and they actually spend less on healthcare. This has all been proven by systematic reviews and meta-analysis. Why is this important? Because again, look at our model. All these things that people are showing up, we can actually target quite successfully by doing P&E with our patients. Now, as we're getting a little closer towards the end of this keynote presentation, I want you to also be aware there is a new way of looking at P&E. Some people look at P&E as a technique, and I will be the first one to tell you I've always looked at P&E as a technique. A patient shows up, they meet a certain number of criteria, they show up in a certain cluster, and I sit across the table from them and I teach him about pain. That's called pain neuroscience education. But what we heard anecdotally from therapists for the last, 10 plus years is, Adrian, thank you. I learned from you. I took the course from you. But, what I've noticed is my behavior has changed in the clinic. It's almost like you sprinkle a little bit of P&E through the clinic, because what they say is they find themselves softer spoken, less expressive. They don't use the words that harm, they use more words that heal, they are more empathetic, compassionate, etc. And we call that now basically pain neuroscience communication. Now, as a scientist, I'll tell you, it's kind of tricky to study. We're kind of wrapping our mind around it, but we are seeing behavior change in the clinicians. Therapists that learn pain neuroscience education actually become more compassionate and empathetic. We have published papers on that. We have now shown that therapists that learn about P&E, they are less burned out. They work longer at their employer. So there's a little bit of our work that's now into the workforce, if you will. So it affects the clinician, which we believe affects the patient. But it's really interesting. And I wanted to put it here because Yo Nice, who's probably one of the most famous people right now in P&E, talks now more and more about pain neuroscience communication. The movement bubble, remember again, we got to change how they think. P&E is one of them. Movement, there's so many different ways. And we take all this incredible movement stuff, whatever your thing is, and we tie it into things like pacing, graded exposure, and we tie P&E into it. Hurt doesn't equal harm. You're sore but safe. Setting goals, and it's slowly getting people from A to B to C as they work their way through. And in the last one, calming the nervous system down, my colleague, Dr. Corey Zimney, several years ago, when we updated our systematic review, came to me and he said, Adrian, and we looked at all this data. And by the way, this slide is basically from about 2018, 2019, so I apologize. We should update it probably very soon. Showed us there is at least 22 things that physiotherapists do on a regular basis that calms the nervous system down. And I would urge you to look at this, look at the handouts we provide, and almost go and check the ones that you're good at, the ones that you're like, oh, I know that. And the ones you're not that good in, you may want to think, I always wanted to take a course on nutrition or mindfulness-based stress reduction, whatever you're allowed to do as a physiotherapist where you practice. In the United States, a lot of our practice acts are opening up to allow therapists now to consult about nutrition and all those kind of strategies. So very, very cool. And I think all of this summarized together is the idea that we are very well equipped to examine and to treat people with persistent pain, picking from these three different areas. And it shows the merger between pain neuroscience education and behavioral medicine. And it's really not an either or model, but actually a combined model. So with that, thank you for allowing me this 20 minutes to do a keynote introduction, and I will be answering some questions that was posted to me by a panel. Now that you have watched the presentation on pain neuroscience and P&E Plus in behavioral medicine, the committee has sent me 4 questions they'd like me to answer. Got about 10 minutes to answer it, so these are going to be relatively quick, brief answers, and hopefully they will give you more clarity on the presentation I just did. The first question I get is, how can the P&E approach contribute to patients with significant orthopedic injuries, such as an amputation or traumatic nerve damage? And this is a great question. First of all, it has never been studied in these settings, to be quite honest. We've never gone into a trauma scenario and doing P&E. But the part that we do understand is, remember, human beings' pain experiences are pretty standard, if you will. And what I mean by that is the underlying mechanisms we deal with, from a sensitized nervous system to fear avoidance, catastrophization, all these aspects always show up in different pain experiences. I can flip it the other way around and that's say, if I was a good businessman today, I would create P&E for back pain, for neck pain, for knee pain, whatever. But the reality is pain is pain. And so, yes, how a person ends up in front of us is different. Some people wake up with pain. Some people develop long-lasting pain due to degenerative changes, but we also get trauma. We get injuries, accidents. We in the United States actually have trained a lot of our soldiers in the Department of Defense. We've trained the medical providers in these strategies. So we do P&E significantly on people with amputations or traumatic injuries or blast injuries, etc. The reality is when a person sits in front of them, they have pain. And the first part is definitely to stabilize him, right? I'm doing a presentation right now, getting ready to do a presentation for emergency room physiotherapists. And point number 1 is we got to medically stabilize and make sure they're good. Everything's okay. Then we do P&E. Because in that space, these patients also are afraid. They're nervous. They don't know what's going on. Making the unknowns known. Now, I would argue that a PNC approach, pain neuroscience communication, of decreasing words that harm and calming and reassurance is a critical element. The interesting thing is, again, if we teach people about pain, what happens? Fear avoidance goes down. We want that. Catastrophization goes down. The nervous system calms down. And that is really cool. We have now done pre-operative P&E to show we can calm that nervous system about 30% pre-op. And so I would say the same stuff happens here. Yes, how they end up in front of us is very different and very unique and obviously extremely traumatizing. But at some point, things will stabilize. And then we have to have these conversations, especially in the latter parts of the rehabilitation. The second question, do physios have a unique skill when it comes to this approach? I can probably answer it both ways, yes and no. We have trained about every healthcare professional out there. We've trained physios, occupational therapists, doctors, nurses. We have trained about everybody there is. And pain is pain again. So technically, any provider that works and sees a patient in pain can actually do this and should be doing this. On the flip side, I'm a physio, so I'm very biased. So I'm going to say, yeah, we have unique skills. So my psychologists that I work with will say things like, I wish I was you guys. And what does that mean? It means basically we can put our hands on people, we can exercise people, we can do all kinds of cool stuff. They cannot. They don't have the license to touch people and to stretch them and to do exercise and manual therapy. They can tell people to go exercise or go to physio. So I think you can look at it both ways. The education part, I think, is probably what everybody can do. But it's the P&E plus part that makes us very, very unique in these skill sets. And P&E, again, very biased, but this is just something that happened in physio, developed in physio, built in physio, and is now expanding out. But I just trained a group of medical residents, physicians, doctors. We just trained physician assistants. We've trained nurses, a lot of different people. Everybody can learn about pain and how to teach people about pain. But to apply it, I think there is a unique skill set that we have, and that's a cool thing. I think that combination is important. I just came back from a conference where I spoke about stress inoculation therapy in the emergency room in whiplash. Really cool work from Michelle Sterling that showed patients did not want to see a psychologist, but they were okay with a physio doing physiotherapy, all the movement stuff, and adding psychological counseling, including things like stress reduction, etc., which fits into this model. So we may be beautifully aligned to give you the physical treatment, but also then dealing with the psychological impairment. Question number 3, what advice would you give to a physical therapist treating a patient with persistent pain who also has a background of PTSD? Again, it sounds very similar to what I was just saying, right? Patients, we meet them at different parts of the journey. And the research right now in whiplash-associated disorders in car accidents show us that 40% of people in car accidents develop chronic pain, and a very large percentage of them have PTSD-like symptoms. We talk about soldiers in war, we talk about trauma, we think about injury, we think about abuse. All of these show up with high levels of PTSD. The neat thing I can tell you today is we have done studies with P&E for patients that have had PTSD. So Tim Benedict is one of my PhD students. He finished up, graduated, super smart guy, and he built a P&E program for soldiers and veterans in the US military that has mild traumatic brain injuries and PTSD, and showed that they can learn pain science, pain neuroscience education, take it on and actually do better than those that don't get it. And so PTSD has obviously significant other parts to it, and we need to sometimes be careful bringing up these memories, those kind of things. And so but there are strategies to be able to get past that. But the reality is we pace ourselves very slowly. We carefully monitor if there is any triggering words. I'll give you a good example. We built for that project, we took some of the pain stories and actually militarized them. So you may have learned from me things like a sensitive alarm system, and then we may talk about a tripwire, or we may talk about something like a guard tower where the lights turn on because there's gunshots everywhere. That could be very provocative for a soldier that has, for example, gone through a war, because it brings up that memory. And so we need to be very careful with the kinds of metaphors we use. That's why a lot of the kind of metaphors we use are simple, they're basic, that most people experience. I understand the need and the want to take stories, for example, and militarize them so that it makes more sense for a military trained person. But I am concerned about the possibility of actually triggering some of these events. So it comes with the skill of applying that P&E, but we've done it, we've tested it in people with PTSD quite successfully. And so I think it's very much an approach we would be using for these patients. And then the last one, physios say that in current approaches, we are coaches, not physios. Is that what we learned for 4 years? What would you tell them? Well, that's a great question. There's a big debate going on. Are we, do we treat patients or clients? And in the motivational interviewing world and skill set, as an example, we often talk about patients as clients, not as patients, because we want to be on the same level versus above them. The patient is below you. You're the provider. A lot of it probably depends where you catch them, I think so. But coaching is a big deal in America right now. A lot of non-physios are doing coaching, those kind of things. I personally do not agree with the idea that they're the same thing. I think we have a very unique skill set. We have very specific practice acts in our country that makes me a physical therapist and not a coach. Coaches cannot be physical therapists. I can, by the way, be a coach if I wanted to. But the idea of a coach, in the big scheme, as people get more chronic, we do become a little bit of a coach, right? We give them guidance, as opposed to fixing those kind of things. But I do think we have very unique skill sets. And if I had a young person sitting in front of me said I can become a coach or a physiotherapist, I would still highly recommend them going to physical therapy. The skill sets are so much more for us to be able to train, and the underlying parts of it is important. Recently, I was on a podcast and somebody asked me, how come you're so good at chronic pain? And I don't think I am. I was trained by very smart people, by the way. And my words that came out very quickly is because I'm a good physio, I'm a good manual therapist. And I had to think about it is because of all those base skill sets of clinical reasoning, hands-on treatment. I'm good at my craft. I do my thing pretty well, I think. and I've put money and time into training myself. I think that makes us very unique. So hear me again. As a physio, I can do coaching, but I don't think it can go the other way around necessarily. So I think we do treat patients. We meet some people that they're more on a patient level, where over time they may become a little bit more of a client that we manage over time, if you will. And we may coach them, advise them, those things, but there is a very unique skill set that makes us physiotherapists. So there's a couple of questions. I hope this helps. You're always free to reach out to me. Again, I wish you so well, and I thank you so much for inviting me. I wish I was there with you, and I fondly remember my time in Israel, and I hope you enjoy your conference.